Good evening everyone. I am Dr. Ravi Dhar, consultant nephrologist at Sri Balaji Hospitals, Raipur. I will be discussing on the topic today given to me as pedal edema. So, coming to the definitions of edema, so it's abnormal fluid accumulations in the interstitial space that exceeds the capacity of the physiological lymphatic drainage. Next will be coming on the mechanism of pedal edema, interstitial edema. So this edema basically results from derangements in the following four factors, like the capillary permeability, capillary hydrostatic pressure, capillary oncotic pressure, and the lymphatic drainage. So if there is a mismatch in any of the four of the followings, it will lead to the edema, and that can be explained by the Starling law of capillaries. So it is stated that nearly as much of fluid is filtered, is reabsorbed as is filtered. So the causes of edema include the increased capillary permeability, under which we have the local causes as cellulitis, the systemic causes are hypersensitivity reactions and the sepsis. The increased capillary hydrostatic pressure constitutes the second mechanism in which the local causes being the compartment syndrome and the chronic venous insufficiency, whereas the systemic causes include the congestive cardiac failure, the cor pulmonale, renal failure, anemia, and pregnancy. The third causes like decreased capillary oncotic pressures include the systemic causes like protein deficiency state, like the chronic liver disease, nephrotic syndrome, protein losing enteropathy, and malabsorption syndrome. The fourth and the last causes for edema is lymphatic obstruction, which is called as lymphedema. So which include the tumors, trauma, radiation, and infections like filariasis. The next term will be the anasarca. So there are two principal causes of generalized edema, which includes the fluid overload, and the second is hypoproteinemia. The effective arterial blood volume is reduced and the renal blood flow is compromised, resulting in the edema. Secondly, the renal angiotensin aldosterone system is activated, and which causes the sodium and water retention. So what are the causes of how to initiate a patient with edema? So we have to take a detailed history, and including in the history we have to look for the site, the history of drug intake, the systemic illness, the variability in the factors, the history of pain, and duration of this edema. So coming to the history proper, first we have to look for the site. Direct arterial vasodilators, which I said antihypertensives, include hydralazine, clonidine, methyl-dopa, and the beta alpha blockers. Whereas the calcium channel blockers, antihypertensive, amlodipine is also one among the most common cause of pedal edema. Non-steroidal anti-inflammatory drugs like ibuprofen and diclofenac also constitute less than 5% of the cases. Hormones like glucocorticoids, anabolic steroids, estrogens and progestins and growth hormones are also one of the causes in few cases. Hydrogenidinations like oral hypoglycemic agents, rosiglitazone and pioglitazone, they also are known to cause pedal edema. Antidepressants like MAHO inhibitor are also caused. So history of trauma and radiation is also important. Trauma and radiations can cause cellulitis and the compartment syndrome. Long-term radiations also can cause the lymphedema. So the important thing about the local examination, we have to look for the distribution of edema, whether it's a unilateral, usually local causes, or bilateral, predominantly systemic causes. The site of edema, bony prominences like medial malleolus and the anterior aspects of tibia, sacrum in bedridden patients as well. We have to look for the tenderness like deep vein thrombosis, cellulitis, compartment syndromes, and it will be usually tender. Lymphedema and edema due to systemic and hypertensive hypoproteinemic states or tenuous state. Pitting edema except lymphedema and mixed edema are the common most other diseases causing pitting pedal edema. Lymphedema is initially pitting. Hyaluronic acid deposition in hypothyroidism is also known. So pitting edema there will be skin changes. Like cellulitis, most common site is leg. It will be red, hot, and solid. Mixed edema will be dry, coarse, and thick skin. The chronic venous insufficiency patients, they have hemosideral deposition, which causes the browny skin, often varicose veins and venous ulcer visible. Chronic lymphedema, hyperkeratotic and papillomatous skin with indurations. And the important sign like Kaposi streamer sign is the inability to pinch the skin on the dorsum of foot near the second toe. So chronic venous insufficiency, that you can have a pictures, you can go through the online availability of this one. Next comes the jugular venous pressure. So JVP distinguishes the cause of vena sarca, whether it's in the fluid overload states, whether it's a protein deficient state. So JVP, if it's elevated in the fluid overload state, the causes can be congestive cardiac failure, cor pulmonale, and renal failure. If it's not elevated in the protein deficient states like cirrhosis, nephrotic syndrome, and Maller-Joseph syndrome. Next comes the systemic examination about the edema, how we approach a systematically to evaluate the cause for edema. So the congestive cardiac failure, we have elevated JVP, third heart sound, and crepitations over the lung basis. Chronic liver disease, icterus, ascites, splenomegaly, gynecomastia, and spiral may constitute the liver disease. The spectrum of liver disease presentation. Whereas in case of chronic kidney disease, anemia, dry skin, and urinary breath are most common. So hypothyroidism, we have bradycardia, skin changes like dry skin and sparse hair and hoarseness of voice. So pedal edema can be unilateral or it can be bilateral. It can be in unilateral, we have acute and the chronic causes. Acute, we discussed about the DVT, cellulitis, and compartment syndrome. In chronic, we have venous insufficiency and lymphedema. Whereas if it's a bilateral, again we can have acute and chronic. Acute, we have drugs. In the chronic, we have systemic and non-systemic. So in the systemic, we have heart failure, liver disease, renal disease, and obstructive sleep apnea. Whereas non-systemic, it can be a drug, it can be lymphedema, it can be pelvic tumor, idiopathic edema. So how to approach? What are the lab investigations? We can do the complete blood count to rule out the anemia and acute cause for anemia. The urine routine microscopy and RFT, chronic kidney disease and nephrotic syndrome can be ruled out through this stage. Liver function test to rule out the chronic liver disease. Serum, total protein and albumin to rule out the chronic liver disease, nephrotic syndrome, protein-losing enteropathy, and malnutrition. The serum lipid profile also gives a clue to the nephrotic and the coronary heart disease. The chest X-ray, ECG, and BNP clue for heart failure. Serum TSH to rule out hypothyroidism and D-dimer elevated is suggestive of deep vein thrombosis. The imaging studies like USG abdomen and kidney ureter bladder, where we have the altered ecotexture of the liver and shrunken liver in CLD and bilateral shrunken kidney in CKD, can give a clue to the cause for edema. The Doppler study can be a clue in case of DVT and chronic venous insufficiency. Lymphoscintigraphy, a radionucleotide tracer is injected into the first vein, and flow of lymph is monitored in a gamma camera. Echocardiography can give a clue to the left, can assess the left ventricular function in case of congestive heart failure. So how will you manage a case of pedal edema? After going through the history, the detailed investigations, we can classify the edema cause, like whether it's due to chronic kidney disease, congestive heart failure, the chronic liver disease. Accordingly, in case of if it's a chronic kidney disease, so we have to restrict the fluid and salt restriction, and loop diuretics like furosemide or torsemide can be given to control the edema. In case of congestive heart failure, salt restriction, diuretics like furosemide, spironolactone, and ventricular remodeling drugs like beta blocker and AC inhibitors can be considered. For the chronic liver disease, fluid and salt restriction, diuretic, furosemide, albumin insufficiency, infusion in case of refractive cases can be considered. So management for hypothyroidism can be considered. Cellulitis can be managed with limb elevation and with the appropriate antibiotics against Staphylococcus aureus. So for deep vein thrombosis, anticoagulant therapy using the low molecular weight heparin by oral anticoagulants like warfarin. The lymphedema, we have to manual massage, compressive stocking, and intermittent pneumatic compressions can be considered. The venous insufficiency, like limb elevation, high compression stocking, can be considered. So these were the management strategies. So at the last of my talk, I would like to convey like edema has a different etiology. So we have to undergo taking a detailed history, we have to investigate the cause, and accordingly we can approach and prepare how to undergo the treatment. So there are various treatment strategies I briefed about. So you have to go through step by step in evaluating a cause for edema, and successfully we can accomplish our target in treating the disease. Thank you one and all.